Welcome, my name's Ian Campbell from Palliative Care Australia, in Canberra on the lands of the Ngunnawal and Ngambri peoples. Welcome to Thursdays at 3, our regular series of conversations with people living and working at the end of life. Today we go inside one of Australia's most highly regarded palliative care services, the Concord Centre for Palliative Care in Sydney. Our tour guide is a palliative care specialist at the centre, Dr. Jessica Lee. Hello Jessica, how are you going?
Hi Ian, thank you for having me.
Jessica, you're also a PhD candidate at the University of Technology in Sydney, so we have lots to unpack and talk about with you this afternoon. But first, a pretty simple question to get us going. Tell us about the Concord Centre for Palliative Care. It seems like a very special place.
It is a very special place. When I finished my training, it was my dream to work here, and I petitioned my now boss to give me a job. So I love working here. We have an amazing team. It's a multidisciplinary team with doctors, nurses, allied health professionals, volunteers, and we work together so well. We support each other to do our best to serve the population that we cover. And we sit within an amazing hospital, which has a really collegiate feel, the Concord Repatriation General Hospital. So it's a wonderful place.
Jessica, keen to sort of add a bit more detail to the, I guess, the look and feel of the Concord Centre for Palliative Care. There seems to be a lot of thought that's gone into the design of the centre. There's lots of light, big windows, looks out onto beautiful gardens. Tell us about that aspect of the centre.
Oh, it's beautiful. It's purpose-built and specially designed to feel more home-like, or as much home-like as you can, while still maintaining those things that we need to provide specialist palliative care. We have 20 beds, many of which are single rooms, and every room opens out onto a courtyard space, and the doors are designed so that the beds can wheel out into the courtyard for people who can't get out of bed. And for those who can get out of bed, they can either go for a walk, they can go in their chair. We have a sun garden just nearby, which is a special garden just for our service, for a little bit of calm and peace. We have the cafes of the hospital available to us. And then there's sort of a general common area where people can sit, where at the moment we have a wonderful volunteer who comes to play piano for us twice a week. And so often we have the strains of music coming through, which it's really lovely.
Jessica, is it a place that patients and families come and go from? I think a lot of people would assume that people perhaps come to a place like this to die. And indeed, that's part of the service, and people do choose to die in centres like yours. But is it also a place where people come and go from? They come to the centre, they get well, and then they go home again? Is that how it works?
Absolutely. So within the inpatient unit in the Concord Centre for Palliative Care, there are some of our patients who come at the end of life in those last days, and they do die with us. Maybe a third, I think. Mm-hmm. And then there's another sizable cohort who actually go home again. So they come in, maybe they had some pain at home, or they weren't walking as well, and their family wasn't really sure what to do, and they come in and they have like a tune-up, I guess. So the team will have a look at their medications, see what we can adjust, get their symptoms a bit better, see if we can either improve their walking or improve their environment so that they are able to function a bit better in their own environment, and get them back home again. As well as the centre, we also are part of a full palliative care service. So we have the inpatient centre, but palliative care in our service encompasses an outpatient clinic where patients who are at home will come and see us for just like a normal visit, like you go and see your GP. And we also have a specialist consultation service which goes into the main hospital, looking after patients who are under the acute teams there, and a community service which can see patients who are at home in our area and unable to come into the hospital for visits.
Such a valuable service. Tell us a bit more about the multidisciplinary team that you're a part of. Who you're talking about?
Well, it keeps growing. So today we were introduced to our new community dietitian and speech pathologist, which is very exciting. And their role is to facilitate people to be able to eat and drink the things that are both easiest and safest and right for them. Their community, they're part of our community team. So in that case, it's at home, but there are also other members of that team. We have doctors, obviously. We have nurses, and in fact, there are subspecialists of nurses. So we have our ward nurses in the inpatient unit who look after patients who are in hospital, and there are also community nurses who look after patients who are at home and can go into the home to perhaps advise on medications or advise how to access services or things that the person might need. We have a social worker. We have a few actually, but the social worker works together with the patient and their family or carers to make sure that they have the psychological support that they need, as well as the practical support that they need. We have occupational therapist who looks at the function of the patient and how they can best fulfill their life or their work, and how to support that as much as possible. We have a physiotherapist and an exercise physiologist who work together to look at the mobility of the patient to maintain their function as much as possible. We have, now I'm going to forget somebody. We have a volunteer service who do some amazing things with our patients. Things like we have a trolley which comes around to our inpatient service, where they can have some chips or lollies or a glass of wine, which is generously funded by donations to our service. So it's sort of free to the patients, or might be able to just spend some time with patients. They also run an amazing biography service where they can actually sit with somebody who wants to tell their life story and write that down for their family or their friends, or even just for themselves.
And Jessica, what you've done beautifully there by sort of highlighting all the facets of your team is highlight the full scope of palliative care. It's just not one thing. It really is that holistic approach to a person's life, and making sure that all those elements of life are being looked after.
Absolutely. We, as a specialty, pride ourselves on providing whole person care, and that includes care of the whole person, the patient, and also the people around them that are important to them. So we do physical, psychological, social, functional, and spiritual care.
Jessica, you mentioned that this was your dream job. Why is that? Where did your passion for palliative care come from?
Well, it comes back to this whole person care. It's about really being able to provide for the person and all of their needs, to help them to live as well as they can and to live the way that they want to live. And I think that it is such a difficult time for people to be diagnosed with an illness that you know can't be cured is not an easy thing to accept. And so it's a real privilege to be invited to share that journey with somebody. And if I can make this time just a little bit better, a little bit easier, or a little bit more rewarding for somebody, that's really meaningful for me.
Yeah. What are some of the, I don't mean to play it down, but what are some of the tips and tricks you've learned along the way? As you say, this is some big stuff, and people come to palliative care with a lot of fears, a lot of emotion. How do you get through that? How do you break that down for people and sort of get over that hurdle of fear that many have about palliative care?
I think everybody comes to palliative care with their own history, their own experience, and preconceptions, which shape the way that they interact with myself and my team. And I think the trick is to first understand where that person is coming from. So I need to understand you before I can help you. And so just asking the question, what do you understand? How can I help you? What is important to you? Really helps me to meet my patients where they're at and provide them the support that they need at that time. And then things always change. Life is a moving journey, and I, if allowed, will walk that journey with them and am able to support them with what they need at the time.
And at what point in someone's journey do you want to see them? When do you want that referral to land on your desk?
Yeah, that's a really good question, and it's a topic of much debate at the moment within the palliative care community. And traditionally, if you were referred to palliative care, that meant you were dying now.
Yep.
But it's not like that anymore. And research has shown that certainly for some people, having a referral to palliative care early in your disease, sometimes as early as at diagnosis, can improve your quality of life, help you to live better, but also help you to live longer. Having said that, I don't need to see everybody straight away.
Yep.
It really is an individualized decision. And so for me, I like to see people when they have specialist palliative care needs. So that might be some complex pain, or psychosocial issues, or they're just, maybe not as well as they were before, and they need kind of a general overview to see what else we can offer. But as well as that, I also like to meet patients earlier in their disease trajectory. Maybe they don't have any symptoms or specialist palliative care needs yet, but I can meet them. But then I don't need to see them, all the time.
Yeah.
If there's nothing that I need to offer right then and there, I can just see them occasionally, or I can let them know how to come back to me when they need me. So it really depends on the individual patient and their needs. I think it's also really important to remember that palliative care is not just provided by a specialist palliative care team, but all our healthcare providers can also provide generalist palliative care. And a part of my role is supporting our team members to do that as well.
So you're talking about GPs, nurse practitioners, that full suite of primary health professionals who can also play a role here.
Primary health and secondary health. So yes, GPs, nurse practitioners, pharmacists, but also oncologists, cardiologists, respiratory physicians. I think all healthcare providers can play a role in providing best practice palliative care. And, these are the tenets of what we provide is making sure that you look at the patient and see what is really important to them to improve their quality of life, to have a focus on quality of life, and to take that into account in any decision making that you undertake with the patient around their care needs, or their treatment, to make sure that they have excellent symptom control, and that those things are regularly assessed, because sometimes if you don't ask, the patient won't tell you. To make sure that the patient is supported psychologically and emotionally, that they're well set up at home, and that they've had the opportunity to think about the future and advanced care planning and what would be important to them if they were more unwell. And I think all health practitioners can play a role in providing those tenets of palliative care.
Sounds like there's lots that the wider health service can learn from taking that palliative approach.
Absolutely.
Jessica, is there a special patient in your mind? This is I guess a passionate service, an emotional service. Is there a special patient during your time that stays with you, that it continues to inspire your work?
Gosh, there are lots, actually.
Yeah.
I mean, every patient is important to me, and I try to be focused on the person who is in front of me when I'm with them, to see how I can best meet their needs. But you're right, some patients do stay with you a bit more than others. I have a beautiful patient at the moment. I have actually been looking after her for 10 years.
Wow.
And she has a grand niece who is the same age as my daughter. So we always swap stories when I see her, and it's lovely to check in with her. I have another patient who he's actually died now, but I cared for him some time ago, and I think he will always stay with me. And he just had this amazing dark sense of humor, and he's an amazing artist, and he had this real roller coaster journey, and it was a real privilege to be able to travel that with them and to help them, pick up when the roller coaster dipped, to be able to pick up from that, and then to be able to celebrate them during the really good times. And that was a real privilege to work with him and his partner. There's so many more. I think the ones that really stay with me actually are the ones that I meet earlier in their disease trajectory, that I've been able to see over a longer period of time, and we really have that opportunity to develop that relationship together. And I think that really helps me to practice, because for each of these patients, I know what is important to them, what their values are, and I'm then able to assist, to tailor their care to their particular person and their particular needs. And I think that really helps me.
I'm perhaps not going to say this the right way, Jessica, but it sounds like you get to know the person before the disease really takes over or perhaps becomes them. You get to know the person.
Yeah, look, that's the ideal. I don't always. Many of my patients come to me when their disease has become all consuming, and sometimes that's just what we need to focus on. There's urgent stuff. This needs to be done now. I just need to get your pain under control, and that is like the most important thing that I can offer to you at that moment.
Jessica, you work in a really multicultural city, Sydney, full of many, many cultures from right around the world. What have you learnt about people's cultural background and how they want to die, and the value of understanding someone's cultural background when you are making a plan for someone's end of life?
Yeah. We do live in a very multicultural area, and the Sydney Local Health District in particular serves a very diverse community. Look, I think the first thing to know is that not all cultures are homogenous. And so I can generalize as to what some cultures might, what might be important to some cultures, but actually you actually need to ask the person themselves what's important to them, because not everybody follows every part. Different people interpret things in different ways. But I guess some of the tricky things include translation. So not all words translate the same in all languages, and not all concepts have equivalent translations. So I find this a really interesting area, and one that I'm really keen to look into more in the future, about how we explain concepts, explain words about palliative care. And it is particularly pertinent in some communities where palliative care or death and dying are taboo. And in some cultures, it's really tricky to explain what we do. So I've been called the do-nothing doctor or the dying doctor, and I really take offense to that, because I don't do nothing. I work really hard to do a lot. I'm not making you die.
Yeah.
The person is dying from a terrible disease, and I'm here to do something to make that a little bit better. But it doesn't translate very well sometimes. So that's a little bit tricky.
Just say, starting with that question and finding out, what are the cultural practices, and having that conversation up front.
So I think that really helps to know. And some cultures practice things differently. We in a Western society are very individual focused. The individual's rights are very important. In some cultures, actually, the decision maker is not the patient in the family. They work as a family unit, and that's something that you need to learn to navigate, which can be tricky. There's a lot of cultural differences. People express pain differently. Some people don't tell you their pain. They don't tell the doctor that they've got pain, because that would be seen as complaining or weak, or maybe they don't want to take medications because that's not acceptable. There's a lot of nuance.
It just adds to the interest of palliative care and the full scope of the service. Jessica, changing hats for you for just a moment. As I mentioned, you're a PhD candidate at the University of Technology in Sydney. Tell us about your research.
Oh yes, well, my research, as part of my PhD, I'm looking at improving outcomes for people with neuropathic cancer pain, which means nerve pain, or pain that comes from damage to the nerves. And it's really exciting, because I'm really hoping that we can help to improve this really tricky symptom that we know has worse outcomes for people. It causes greater distress and greater functional impairment than other kinds of pain. And so we are working to better understand it and better understand how to do research for these patients, to look at new agents which might help people with nerve cancer pain. But I think the other thing about my PhD is that it's providing me with the skills to do a whole range of research, looking at all different facets of improving palliative care for patients, improving symptom control. And our team, so I don't work alone. We work with a team. I work with a team here at Concord, and I also work with an amazing team at Impact UTS and with a group called the Cancer Symptom Trials. So I have lots of teams, lots of hats, but all amazing researchers who are really looking at trying to improve each a little part of how we look after people with palliative care needs.
Mm-hmm. It's great work you're doing. Jessica, just finally, how does, I guess, working with death and dying shape how you live your life away from work? How does working in palliative care influence how you live your life?
This is a really tricky question, Ian. I think. I think that one of the biggest things that I've learned is that the mind is very powerful, and your attitude and your approach to life can really shape your experience of life. And it can be harnessed if it's used in the right way. It can be harnessed to really help you, I think, to improve your symptoms, your quality of life, your relationships, just your life, I think. And I see that in my patients, and I try to take that into my own life, although, not always easy.
The power of the mind, hey? Thank you so much for your time today, Jessica, and sharing your work and wisdom with us. We're all better for it. Thank you.
Thank you, Ian.
Dr. Jessica Lee from the Concord Centre for Palliative Care. Thank you so much for tuning into Thursdays at 3, whether that's via PCA Socials or Spotify, and engaging in matters of life and death. You'll find advice, tools and support at the Palliative Care Australia website, where you can also make a donation to support our work. See you next Thursday.